Welcome to the video answers for this Part 1 question set. Let's get started. First question, what potentially fatal autoimmune skin disorder is caused by IgG antibodies against desmosomes? Well, this is a blistering skin disorder called pemphigus vulgaris, where you have antibodies against the desmosomes. Well, that's great, but what are desmosomes? Well, that leads to our next question. What's the difference between a desmosome and a hemidesmosome? Well, desmosomes connect cells to cells kind of side to side. And then a hemidesmosome is a structure that connects an epithelial cell to the basement membrane. So in pemphigus vulgaris, there are IgG antibodies against the desmosomes. And there's another blistering skin disorder called bullous pemphigoid, where you have IgG antibodies against hemidesmosomes. Next, what's the classic presentation of granuloma annulare? Now, there's not a ton of dermatology on step 1, but you will need to be able to identify a few common lesions, either based on their descriptions or be able to recognize them from a photograph. So granuloma annulare is usually asymptomatic, meaning it doesn't itch or burn or cause the patient any problems other than the look of the lesion. It's generally a non-scaly, slightly erythematous plaque that's annular or ring-shaped. The edges are irregular, but they're well-defined, and the border is kind of thick and rope-like, which is going to help you distinguish this from ringworm or a dermatophyte fungal infection, because those are generally going to be flat. Granuloma annulare usually starts small and then it grows outward centrifugally. The lesions are usually localized, but sometimes they can be generalized or disseminated. And this is usually found on the wrists, on the ankles, or the dorsal surfaces of the hands or the feet. The palms and soles are usually not affected. Next, a 66-year-old man is involved in a motorcycle accident and suffers a head injury that leaves him in a coma. Prior to this injury, the man met with his lawyer to write out specific instructions in case an event like this happened. So what are these instructions called? Well, this is a written advance directive, also known as a living will. Next, an 18-year-old man is brought to your office for delayed onset of puberty. Physical exam confirms a small penis and testicles for his age, as well as lack of facial, pubic, and underarm hair. The patient also reveals that he's never been able to smell. So what's the likely diagnosis? Well, this patient has Kallmann syndrome. This is a combination of anosmia, the lack of the sense of smell, and hypogonadism. The hypogonadism is due to decreased synthesis of GnRH in the hypothalamus. So with no GnRH, you're not going to get any release of FSH and LH from the anterior pituitary. Therefore, you get a lack of secondary sexual characteristics. Next, a 45-year-old woman who's been taking prednisone for control of rheumatoid arthritis symptoms has recently been diagnosed with Cushing's syndrome. Other than exogenous steroids, what else can cause Cushing's syndrome? So the most common cause of Cushing's syndrome is taking exogenous steroids by far. But in terms of other causes, you could have some pathology of the adrenal gland, like a functional adrenal adenoma or nodular adrenal hyperplasia. So those would be examples of primary adrenal excess. Then in secondary adrenal excess, the adrenal glands aren't really the problem. Secondary adrenal excess means that there's too much ACTH being produced, and that ACTH is stimulating the adrenal cortex to release excess cortisol. So the adrenals aren't the problem, they're just following orders from this excess ACTH. So one form of secondary adrenal excess would be a pituitary adenoma that secretes excess ACTH. We call this Cushing disease. So Cushing syndrome is where you have all those glucocorticoid effects. Cushing disease is specifically a pituitary adenoma that causes it. And then the other type of secondary adrenal excess to know about is ectopic ACTH production from a non-pituitary tumor, such as a small cell lung cancer. And then how does the level of ACTH help differentiate between these? So in the case of an ACTH producing tumor, the level of ACTH is going to be high. But in the case of a cortisol-producing tumor, that high cortisol is actually going to suppress ACTH through negative feedback on both the pituitary and also on the hypothalamus. So ACTH is going to be low. Next, describe the flow of blood into and out of the thyroid gland. I know this kind of seems basic, but it does show up on step 1. So let's start with the arterial supply. The external carotid artery gives rise to the superior thyroid artery, and then the thyrocervical trunk gives rise to the inferior thyroid artery. Then for the venous drainage, there are 3 veins: the superior thyroid vein, the middle thyroid vein, and the inferior thyroid vein. Next, a 30-year-old man is undergoing the Schilling test to investigate his B12 deficiency. So what must be present in the enteric system in order for vitamin B12 to be absorbed? This is intrinsic factor, which is produced by the parietal cells in the stomach. And then remember that this B12 intrinsic factor complex is actually absorbed down in the terminal ileum. Next, the part of the brain responsible for attention and alertness has been implicated in schizophrenia, PTSD, Parkinson's disease, narcolepsy, progressive supranuclear palsy, depression, and ADHD. So what part of the brain is this? And there's a hint. A lesion here results in a coma. So we're talking about the reticular activating system, which is part of the midbrain. It's what helps keep you awake during a long, boring video lecture. It keeps you attentive, it keeps you alert, it keeps you activated. So it's the reticular activating system. And if you lesion this reticular activating system, you could have a coma. Next, what's the definition of first-degree AV block and what are the symptoms? So first-degree AV block is defined by prolongation of the PR interval greater than 200 milliseconds. So that's 5 little boxes on the EKG or 1 big box. So in first-degree AV block, there's no blocked beats, there's no bradycardia, there's nothing. This is 100% asymptomatic. It's only found on EKG. And I want to mention it can be easy to overlook first-degree AV block unless you make sure that you're looking at the PR interval and measuring it. So you need to be very systematic about how you interpret EKGs. Next, what are the differences between delirium and dementia, and which is more commonly reversible? So this is a really important concept for step 1 and level 1, being able to differentiate between delirium and dementia. Delirium is a waxing and waning level of consciousness that has an acute onset, and it's usually secondary to some other acute illness. It's very common both in the ICU and in the general medical wards. And it's important to note here that delirium, unlike dementia, is usually reversible. Now contrast that with dementia. Dementia is characterized by a slow decline in cognitive function with no alterations in level of consciousness. These patients are alert, they're conscious, they just have loss of cognitive function. And instead of an acute onset, this is a slow, gradual onset and a gradual decline. Dementia can be caused by Alzheimer's disease or vascular disease or a handful of other chronic diseases like dementia with Lewy bodies or frontotemporal dementia or even HIV, but it's not associated with an acute illness. And also dementia is usually irreversible. All right, that's the end of this question set. I'll see you next time.